I like to talk at the TI whenever we have the opportunity to be part of a conference about things that either matter to the patients I see every day or that matter to me personally. So I want to know how many here have had a cough in the last year that just went on and on and on. Okay, a lot of people, for those online, I can see you like through the camera, raising your hands, yelling at your computer. Daycare parents, I see you. So this is me, this is you, this is our patients who come to the pharmacy asking for over-the-counter stuff. It's people who come to clinic and they want some help. So that's why I want to talk about it today, and we're going to talk about what works. I don't have any disclosures, but this is Italian gymnast Giorgia Villa, who was an Olympian. She was sponsored by Parmigiano Reggiano. I don't take money from Big Pharma, but I could be persuaded to take money from Big Pharma. And my email address is in there if you want the slides or if you know anybody who has a cheese company. So my first question to you is, and I'm sorry, at home you won't be able to say this, but I want you to just think about how long does the average cough with a upper respiratory tract infection last? 6 weeks? Whoa. 2 weeks? 2 weeks? Lots of nods? Yeah, I mean, we don't really know. There's information from the paper in 1967 that said somewhere between 0 and 33 days. And then there was a review in 2013 that said the mean duration is 17.8 days. In the last session, somebody yelled out 18, like right away. And I'm like, did you read? They must have read the same paper as I read. So it kind of took the fun away. But 18 days, that's pretty long. And I'm mostly interested in those coughs that go beyond that, beyond the acute phase, because those are so frustrating and they seem like a great injustice to suffer. And patients really struggle with them. They're arbitrarily defined. So a subacute cough, which we'll focus on today, is 3 to 8 weeks. And these are usually post some kind of upper respiratory tract infection without red flags. In the literature, sometimes it says with a chest radiograph that's normal. Most of my patients wouldn't get an X-ray. It's just it's not necessary, it's not appropriate. But that's one of the official definitions, and it seems quite common. There's a huge differential for cough, which we won't go into. We're just going to talk about that little circle today, which is one kind of cough, subacute cough. And this type of cough must be differentiated from others in the sense that there shouldn't be any red flags in your patient, right? If they're not eating, if they're coughing up blood, if they've had a cancer, if they have severe asthma or something, you're not going to think of it as a normal subacute cough. You're not going to want to follow any of my statements today. Usually they've had a cough cold beforehand, and it's not something obviously treatable. So whooping cough, even people who are vaccinated can still get pertussis. So you may want to test for that if you have a suspicion they have typical whooping or that kind of thing. When I planned this talk, I was going to talk about long COVID, or I guess the length of time would be like medium COVID. But none of the literature, none of the papers I'll present today include patients with COVID because they're all done before the pandemic. The reviews were done after, but the actual randomized controlled trials were done beforehand. And then there's this post-nasal drip thing, which is now called upper airway cough syndrome, UACS. And I don't know how to differentiate those patients from patients who just have subacute cough that's not post-nasal drip. There's no literature to guide this. I hunted and couldn't find anything to say, should we treat people first for that? Anecdotally, and again, expert level consensus is that people will tend to have congestion or more nasal symptoms, not just a cough alone, but some of these patients may only have cough. So if you choose to treat them first, that's fine. I can't tell you whether that's a good idea or not. There's nothing to guide us. And then again, it's arbitrary, that 8-week cutoff. But if any time when you're caring for this patient, they keep coming back to your pharmacy, you notice they're really hot and sweaty, or they're, they don't look good, or, they're just having some symptoms that are concerning, or they hit that 8-week mark, it's a good flag to say, do I need to look further? Because there might be something else going on here. So just a reminder. Why do we get these coughs that last forever? Nobody knows. Some people made a guess that when you have an infection, it leads to inflammation. Inflammation really leads to damage to the mucosal lining of our airways. That's uncomfortable. We get more mucus production, more clearance. We also get more sensitivity, and that triggers that cough reflex. So maybe that's how it's happened, and that's how it's happening, and that's why all the different drugs that I'll talk about relate to those potential mechanisms. coughing is terrible, right? It's a huge economic burden. People spend, the number was $11 billion in the United States per year on over-the-counter cough remedies, not including online sales. That's a lot of money. That's not just on cough, that's all cough, cold, flu kind of stuff. That's a ton of money. And people miss work. I know if I'm coughing at work, it's been 4 weeks and I'm like, no one else is, I'm the physician who's on call that day. No one else is going to fill in for me. But if any people, my patients, if they have to miss work or they're not able to care for their children, like it's a huge problem. So this is a great burden. And so we all want to figure out some kind of solution for this. So as a family doctor with a bit of extra training, understanding of evidence, and one who loves to ask these questions, I use the PICO structure. And I wanted to look at adults with acute cough, given anything that you could give them to try, compared to anything else, maybe placebo, to see, could it change how people feel in a meaningful way? Does this work? Do you feel better if you take this for your cough? That's really what I was trying to answer, a very practical question. And I wanted to look, the easy answer is like find a really good systematic review, and then you get your answer. And if I couldn't find that, I thought I'll look at randomized controlled trials. So there's a bunch of systematic reviews, a few in subacute cough, and then some in acute cough, because there wasn't a lot in subacute I looked at. And you don't have to read that. It's to show you, all of them say, either there isn't enough evidence to say if it works or not, or it doesn't work. There's one of those was inhaled corticosteroids, and they say like the evidence is poor, there's lots of methodological problems, like maybe there's a benefit, but we have to downgrade that because the quality of evidence is poor. So they're stuck with this. And we don't want to be, at the TI, sometimes we're known as nihilists, like doesn't work, don't use it. And then, but like tomorrow you're in clinic, you're at the pharmacy, the patient's asking you what to do, and you're like, well, nothing works, sorry, bye. It just doesn't work. So I wanted to find us a little bit of hope. And what I did is I looked at different drug classes, looked for randomized controlled trials, and then in the upper corner there, I've got like a symbol for me and you. Yellow question marks like, maybe there's something to it. Green plus is that looks positive. Red X is like, no, that's not going to work. And some mixture of those symbols conveys my uncertainty. So for inhaled corticosteroids, this is the first kind of puffer I'm going to talk about. These probably suppress airway inflammation, which is one of those possible mechanisms. And there's a lot of systematic reviews on these, but really the systematic reviews only look at two randomized, they all include the same trials. So these two randomized controlled trials, which were subacute cough population over 2 weeks. And the first one found no impact on cough scores. The second one found there was a little bit of improvement in non-smokers, which is a pre-specified, now you all know about subgroups, pre-specified, so they didn't just make this up after the fact and go looking. But the difference was only about 1 in 6 on a point scale, which we learned from Ola. These scales, who knows if they're meaningful. But the interesting thing is the change was about 1, but the baseline fluctuation in a person, how they rate their cough score, like their pain score, was also 1. So it wasn't a huge change. And we also know that when patients say how much better their cough has to be for them to think it's a meaningful improvement is 54% reduction in cough frequency, or there's different Likert scales, and they say like 2 points out of 7 on the Likert scale has to differ for them to think a drug is helpful. So I'm not sure this really meets that threshold. It was pharma funded, and there were some acute and chronic cough patients in there, which contaminates it. It's not a pure subacute cough, but in reality, we see these people, and they can't remember when their cough started and whatever. So that might be realistic. So when you pool the data, according to these meta-analysis, you'll see placebo has a 50 to 56% impact, and the inhaled corticosteroid further improved that somewhere between 2 and 13%. So there was a statistically significant difference. And in the trials, again, this applies to all of them. They're also short that they usually say there's no difference in harms in the groups in the trials. Some of these trials are like 3 days long, some are 2 weeks. But we all know if you prescribe inhaled corticosteroids, as we forget who was speaking about in the portrait talks about inhaled corticosteroids. So you could get increased risk of pneumonia, you can get thrush, those in palliative care, we see that all the time. And then there's also the environmental impact. So every drug we'll talk about probably has some harms. because there isn't a lot of information, I also looked at the acute cough literature to see could we generalize that. I don't know if we can. There were trials in acute cough of inhaled corticosteroids, and they found that objective measures, so they had a tape recorder that kind of made a mark on a paper when they had a cough and counted cough, those types of things improved. So the objective measures are better, but when people rated their cough scores, they didn't improve. So I don't know if is that meaningful to patients? Probably not. And they've not looked at oral corticosteroids for subacute cough. Different kind of puffers. These are the blue and green. These are AI generated, angsty young men. So anyway, these drugs haven't been looked at independently, but there was one trial where they were combined. Just 92 patients. Again, all these trials suffer from being very small. And when they combined them, it wasn't even inhaled. It was actually nebulized, which probably could change how we interpret this. But anyway, it's the best I could find. And it found that at day 10, there was some difference in reports of the number of people who had a cough that was continuing, but by day 20, there was no effect. So maybe it worked in the middle ground. How did they choose day 10? Arbitrary. I don't know. That just seemed like a good midway point to a trial they thought they could do. And the big problem with this trial is that a lot of people dropped out, or they weren't actually dropped out. They were people, if they had adverse events, they were like forced out. They just didn't include them in the analysis. And the same, if they got worse, they also didn't include them in the analysis. So I don't know that you could really trust that. Similar, a bunch of harms, which you guys probably already know about. I mentioned there's no RCTs of each drug individually. Leukotriene receptor antagonists, so that's like Monteculast, which I don't have a good, how do you make a cool picture about Monteculast? I don't know. So you get it coming off the shelf. And the long story short, you see the red X there, no evidence of benefit in a randomized controlled trial with subacute cough. That was 2 weeks and decently done, although there was high attrition, 67 patients withdrew. And most of these trials, they don't do intention to treat analysis. So were those people who felt horrible? Possibly, because I learned, I didn't know this before, that, of course, there's the common side effects like reflux and headaches, but psychiatric effects are being reported more and more to Health Canada. So there's now some warnings to do with that, with this drug. I couldn't find much about acute cough, but in chronic cough, there's a Cochrane SR in children, and it shows these drugs don't work. So I would say pretty firm, no, don't bother with these. I think that's clear. Antibiotics, who thinks these are good for acute cough? Yeah. Not studied in subacute cough, probably the same is true. I thought a useful study is the Cochrane systematic review on giving people no antibiotic, immediate antibiotic, or delayed prescription, which shows basically the groups fare similarly. There was a marginal decrease in how long the cough persisted in that delayed group, and the people got antibiotics. That seems interesting. And the people who got the delayed script, of course, they actually took fewer antibiotics than those who got the immediate prescription. But the problem with this, thinking maybe antibiotics, maybe it has an anti-inflammatory mechanism or something. Yeah. But they weren't randomized. This was what people were choosing in some of the trials. So I don't think you can trust that that's a real effect, that their cough was a little shorter. Maybe people who felt sicker wanted the treatment earlier or vice versa. So I don't know. I wouldn't prescribe antibiotics for subacute cough. Opioids. Okay, I'm a palliative care doctor. This is shocking because we use them every day, mostly for dyspnea, but also to suppress cough. And these are not palliative care studies. These are one subacute-ish cough. So again, it included some acute, some chronic cough of 30 milligrams of codeine twice a day. Didn't do anything. That was shocking. And it was a trial that only had 33 patients, so it's possible that could change if they did a bigger trial. There was another drug in the trial, and they didn't specify the form. Some people are like, no, they have to have syrup. Can't be the tablet. This trial didn't even say which modality it was, so I don't know, but we know that the modality actually probably doesn't matter. And I'll get to that later in terms of efficacy for that. But when it comes to acute cough, there are a couple of trials. These are older trials, but they looked at different doses. So one had 30 milligrams a day, one had 30 milligrams QID, no difference in cough scores, and 50 milligrams, no difference. And I was really, is anyone surprised by this? Do you prescribe codeine or morphine or some kind of opioid for that horrible cough? They keep coming back. Yeah, like that's just a thing we do. It seems like it works anecdotally, but I don't have any literature to support that. GABA drugs, we know Tom and Aaron love to hate. Hate to love, I don't know. Maybe they do something for someone. And when it comes to cough, I was searching PubMed for like subacute and RCTs, and I found this like, oh my God, they've tested pregabalin and subacute. No, the title says subacute, but every single patient there had at least 8 weeks of cough. And they were referred to like a tertiary referral center for a refractory cough. So they tried everything else you've ever heard of, and it didn't work. So then they put them on pregabalin or dextromethorphan versus dextromethorphan. And they found just statistically significant impact on quality of life, less than 10 points on a 100-point scale, probably not that clinically meaningful, right? 10% difference. And if they'd included more patients, this was 45 people, and 15 dropped out. So that whole fragility thing we learned about this morning, this is fragile, super fragile. You could break that. Just blow on it, done. Or cough, and it shatters. So the chronic cough, there's more literature there on gabapentin. There was this systematic review, which is not done well. They include prospective, and there's trials, and that weren't blind. There's not randomized, lots of issues. But they claimed that gabapentin reduced cough frequency and other things like. So, but maybe there's something there, because as I was reviewing all this literature, I began to see there's this pattern where chronic cough seems to become this thing that we can't find, we do all these tests, we can't find anything to explain it. We know people are suffering from it, and then we start giving them drugs that work on their neurologic system. And those are the ones in the trials that seem to help. And so in a few years, it will be probably lumped in with the central sensitization things. There's something about people after infection, they become hypersensitive, that cough reflex is just going more than it should, like their fibromyalgia, like and there's probably some mechanism there we don't understand, but I'm thinking this is why these type of drugs might be seen to work in that population. Is that generalizable to the person who had a cough or cold and is coughing 4 or 5 weeks later? I don't know. These are pretty dangerous drugs, so I put question mark, like maybe they could work. I don't know. I'm not sure I would use them. Okay, over the counter. What kind of stuff do you, if you're a dispensing pharmacist or a PCN pharmacist or a nurse practitioner, what do you tell people over the counter? Like, what do they take?
Ivy leaf extract.
Ivy leaf, yes. There are some observational things about that. I don't know what the active ingredient is, though. What other things do you see?
Chlorpheniramine.
Honey?
Chlorpheniramine.
Chlorpheniramine. What's that?
Or, sorry, maybe I got the wrong one. It's antihistamine.
Antihistamines, yeah. I don't know there's like 1,000 antihistamines, right? So, okay, yeah, antihistamines, I see that often. Yeah, what other things? Honey, I heard that, yeah.
Topical eucalyptus.
Yeah, eucalyptus Vicks Vapor Rub. So we're going to talk about the ones where I could find research, and not everything today, but if you have questions about ones that I don't talk about, come see me after. Honey. So I couldn't find any randomized controlled trials on subacute cough with honey, but mixed with coffee. Honey paste with coffee extract versus pretend honey, like synthetic extract of honey and synthetic coffee mixed with prednisolone or guaifenesin. And they randomized people to these different groups. They mixed it with water and they drank it 3 times a day. And the people in the honey and coffee group, their frequency of cough decreased by 93%, which would be clinically significant. But we all know that, like instant coffee, Dee Mangan's not here. Oh yeah, she is. You guys drinking your instant coffee in New Zealand is horrible. Everyone drinks it there. It tastes disgusting. Well, I don't know. I've got a friend who lives there, and she's like, oh, it's normal. Everyone drinks this. Yeah, flat white's okay, but at home, people are drinking. It's disgusting. Anyway, you can tell the difference between, like instant coffee and real coffee, or fake honey and real honey, right? So these studies, they tried really hard to blind it. They did, but I think this one was done in, I think it was Iran, where people use a lot of honey for coughs and colds already, and so they're going to be familiar with that taste. And so I'm not sure that the blinding was adequate, but still not that many harms. And when you look at the Cochrane systematic review, it still has the same issues with blinding and some other methodology issues. But in kids, it seemed like it was helpful for cough and sleep in children. So maybe there's something there. I'm more hopeful than I was for some of the other drugs. So there's tons of stuff. A lot of the trials I could find in acute cough come from this systematic review by Smith. It was a Cochrane methodology. And in that study, you won't be surprised to hear that 8 of the 12 pharma-funded trials found positive effects for the drug, and just 4 of the 15 that were not pharma-funded found that the drugs worked. So obviously there's something going on there. Dextromethorphan was looked at. Again, these are not subacute cough studies, but in acute cough, there was 3 trials in adults versus placebo, and objective cough counts, so those machines that measure and things like that, did have decreased scores that were statistically significant and some fairly meaningful ranges. I'm not going into the detail because this is acute cough rather than subacute, but just to give you the sense that like maybe there's some evidence there of objective and subjective improvement. But in pediatrics, no changes. Expectorants like guaifenesin, nothing in subacute cough in terms of research. In acute cough, there are 3 trials, mixed results. One was yeah, one was nah, one was depending on which outcome they looked at. And the outcomes, they picked some weird ones. So I didn't really know how to interpret this. It's like, probably more research would change our conclusions there. Decongestants. So they're rarely available just on their own. It's usually a combination decongestant with an antihistamine, not studied in subacute cough. Plenty of harms with the anticholinergic stuff with the antihistamine. And there was a couple of trials. The larger of the trials found no differences in a subjective sort of cough diary. The other one did find, again, points, this time the scale's out of 4, 0.6 difference on days 3 to 5, but not later. So you wonder, again, they're looking like, oh, day 3 to 5 looked good. We'll report that. What happened on day 2? Why didn't it work on day 2? But it worked, so, and the trial's so small that could just be statistical chance. So, and in kids, these don't work. So I'm not too excited. Antihistamines, all you get is side effects, so don't bother. Menthol. So somebody mentioned like eucalyptus oil. Usually these things are in combination. So mixtures of these things. There's different versions. So there's the topical, like the Vicks VapoRub, and there's that famous study in pediatrics. The parents of the children put Vicks under their nose, and then they had a little jar of placebo or Vicks that they had, no brand names, whatever, VapoRub, that they had to rub on their child's chest and let them sleep. And the parent was not allowed to remove their Vicks stuff that night, and they had to rate their sleep, their child's sleep, and different cough. And they were supposed to ask everyone in their family not to tell if they could smell a difference and all these things. Anyway, small study, 138 kids, but there were some improvements there that people felt were meaningful. So that's where a lot of our hope comes from with this one. Oral lozenges, so what was Tom saying? Fisherman's Friend and some of the other ones, they have menthol and like it tingles, it feels, it kind of burns, like, yeah, the burn is good. Actually, it's associated with longer cough duration. That's really good marketing. Tastes awful, but it doesn't work. Makes it worse. So I don't know. I would, if patients are popping those, it's an association, but there's some potentially causative role that Johnson can establish. So I'd encourage you to look at that paper if you question that. And then it's never been looked at in inhaled form in subacute cough, whatever, but in artificially induced cough, when you get the fit test and they put the capsicum or whatever, and then you get that, they did that, and if they gave menthol before doing that, it reduced the amount of cough that people had. So there might be something to it. Just don't let children eat eucalyptus oil, they will die. It is not good. This lady looks unimpressed with the evidence or with being sick in bed with, I don't know, there's like dogs and children. It's not AI generated, but I swear there's like a foot in her face and a bunch of random, it's something I found on Flickr. Anyway, these are all Creative Commons licenses. But I was talking about hope before, and I want to kind of bring it all together now. So remember the slide with the puffer? I buried the lead. So who here noticed the magnitude of that placebo effect? 50 to 56% benefit for placebo, and inhaled corticosteroid added somewhere between 2 and 13% additional benefit to that. That's a huge placebo impact. Ridiculous. That's amazing. Oh, yeah. So this is one of those, at the beginning, I looked at the systematic reviews, and this was one, and they kind of did their review, and it included subacute cough papers, but also these other ones are chronic cough. And on the bottom is the placebo treatment effect, and on the left side is the ICS treatment effect. And you'll find they kind of both range 60 to 80%. And the subacute cough, those numbers are really high. It's less for the chronic, but it's quite high. And this is not surprising because there's already a big body of literature that shows a huge placebo effect in acute cough for basically any remedy. And that ranges from 50 to 70% in acute and subacute cough, which is replicable across different studies. And it's less in chronic cough. And it goes down over time. And why do you think that is? Because people get better on their own. So over time, people cough less, their cold goes away. Yeah, it goes on for weeks and weeks and weeks, but it does get better for the majority of patients. So I don't know what proportion of that placebo effect is explained by regression to mean or self-remission, but a lot of it. We need randomized controlled, but controlled with no treatment, not just placebo, to understand the magnitude of effect, and we don't have those. Some of that might be confirmation bias. When people get a drug, they say, "Oh yes, doctor, I do feel better, thank you. Yes, the puffer's working." You're like, "Yeah, but you have a broken knee." Just giving them something will make people look for the things that confirm that it's working. I feel better. And we harness this all the time in palliative care. "Oh yeah, you do great. Don't care how it's working. It's working." N of 1 trials every day, right? And the caring interactions, just spending time with people, saying, "Oh gosh, your cough is awful. Let's do something about that." Yeah. Boy, that must really be affecting your ability to care for your frail mother. Spending time with patients we know also improves. And even in clinical trials, it's been shown that just being in the trial can help people feel better. The details of the placebo probably matter. It hasn't been looked at in cough, but we know from migraine studies that the modality matters. So if it's acupuncture versus a pill, like the more invasive and nasty, the better. And there's some theory that sweet taste can reduce cough, and we know sweet taste can reduce pain in children. There's something neurologic that happens there. Cost, more is better. So there's a Parkinson's study and a pain study that show the higher the cost of the placebo, the more likely it is to be effective. And if it's on sale, it's less effective. So that might be why you never see, you're like, "Oh, how come it's never on sale at the drugstore?" Maybe it's a marketing thing. They know you're going to think it works better if they don't put it on sale. I don't know. And then the framing, like how you say, this, "Oh yeah, Mr. Smith, you have had a rough ride, but you know what? I got something for you, and it's going to where I have so many patients, and as soon as they take this, they feel way better." That matters. That really influences the impact. So what can you do? Yeah, don't get people, they could stop smoking. That might help their cough. Don't give them cigarettes. Time. And maybe you want to give them something that they can use over time to feel better. Watch out for the side effects. I would say, like, watch out, don't give them something expensive, but maybe with the placebo, maybe you want it to be expensive. I don't know what to do with that. But be conscious of other impacts, including the environmental impact, the hassle factor, how many times a day they have to take it. And if you really feel like, they want something, they're not leaving my office without a puffer because their best friend Bob had a puffer and he's better. He got to get that. He wants the blue one. If you feel you have to do that, consider a delayed prescription. Say, "Okay, you know what? We've talked about it. You understand the harms, risk, whatever. I'm going to give you this prescription. I want you just to wait a day or two, see how you're feeling. If you're still feeling crappy on Thursday, get that filled." And you'll find that not everybody fills it. That's fewer people exposed to the harms. And then you're going to the safety net come back, if you're throwing up blood or losing weight or whatever, or at 8 weeks if it's still there. Again, arbitrary. There's a little bit of a script that, again, these handouts will go around. You can look at it later, but it's basically like acknowledging how awful this is, how disruptive and problematic this is. Your cough will go away on its own. It might take forever. It might feel like forever because it is forever. And a lot of prescription things aren't truly effective, but here's what we should do. And you can pick something. Personally, based on this literature, I think I'm going to pick honey. I might try some DM for some patients. I might still do some codeine occasionally for my palliative patients. Or I don't care. It doesn't matter which opioid. They just haven't studied other opiates. They're probably all the same in terms of central cough inhibition. So hydromorphone or whatever. And then, of course, telling people, watch out at 8 weeks. We need to check in. So it's a whirlwind tour of everything I know about subacute cough. And if you have questions, I'd invite those now.
So when it was available, patients swore by Cotridine. That's just a comment. Okay. if honey given with coffee, especially at night, it may keep the patient awake.
Yes.
Yeah.
And hyperglycemia and weight gain, if they're just, I don't know, they didn't separate out caffeine. There's proposed antitussive mechanism of caffeine or coffee. So they need to do a trial separating them, but
Sure.
yeah.
An infant may be 2 to 4 months age with possible viral bronchitis, unlikely bronchiolitis, chest is clear, tired on even symptomatic prescriptions, aerosols with Decadron, no help at all. Could a trial of a small dose of an antitussive with hydrocodone like Novohistex DH be tried?
For an
Especially-
infant,
Yes.
I'm not a pediatrician. I'd be pretty leery about starting opioids in an infant. I'd probably call a pediatrician just for some advice about what they might suggest doing.
Okay. And any questions or comments in the room? Oh,
Sorry, I slagged off your coffee. No one can afford a flat white. That's a problem.
It's true. I know you can mortgage your house to have a flat white every day. I was thinking when you were talking about honey that Canada should be doing the maple syrup trial, right?
Yes. Good idea.
So I have just a comment about the, diagnostically trying to separate out the postnasal drip. And I'll just tell you what I do, which is not evidence-based, and you can shoot me down if you think that it's not supported. But if I think it might be postnasal drip, I use an Atrovent nasal spray because it works really well as a drying up agent, and you don't get, I use it a lot symptomatically because you don't get tachyphylaxis in the same way that you do with oxymetazoline and things. And I find it really useful to figure out with the patient, is this postnasal drip or not? But I don't know if anyone else does that or if you think that's,
I started going down, I was like, no, that's not happening today. There's a lot of literature about inhaled corticosteroids and inhaled ipratropium nasally.
But this is nasal.
Yeah, but but I don't know if it's never seen as diagnostic. I think there's a lot of therapeutic trial. If you want to do that, that's fine. It's not going to be, that's postnasal drip. You may get better in time. It may be the same philosophy as subacute cough, right?
Maybe placebo.
Yeah. Worth a try if your patient accepts possible harms, right?
I've been hearing a lot of the ICS side effects of like pneumonia and all that stuff. So how long do you have to use an ICS puffer or medication to see those potential complications or adverse effects? Is it just a week or is it after a month or two? Like what happens if you just say a delayed prescription, use it for a week and you'll be done? Are you facing the same side effects or?
I don't know. The trials here, they found no side effects like that or no differences compared with placebo, and the maximum length of those was 2 weeks. You could look at in the references when these will go out, there's the chronic cough systematic review that may report more robustly on that. But often the patients that are in the trials are so healthy to begin with, they're not already immunosuppressed, it's often the stacking, where I would see over time those things come up. I don't know if Aaron or anybody else has an answer for that one, but probably it'd be fine in the short or less problematic in the shorter term. Yeah.
Come across steam inhalation?
The question was about steam inhalation. Yeah, I had a slide with a train and some steam. I couldn't find anything about, not a randomized controlled or not even observational, stuff that could tell us anything. Some people feel that feels better, especially for nasal congestion. I don't know for cough, maybe in the moment it can suppress it, but it's pretty hard to do that all day long. So I guess if you're really desperate, but you might fall asleep in the bowl of hot water and could be harmful too. I think that's it. Oh, we've got one more and then I think we need to go for our break.
I'm just interested, nothing's brought up about post-viral reflux-induced cough. I find that's actually quite relevant.
There is a lot of cough that's attributed to gastroesophageal reflux, and some of these trials, patients had already tried a PPI or something beforehand, and so those people were screened. Not all of the trials. It's certainly one of those on that huge list of differential, like a bit of reflux masquerading as a cough potentially. For patients who if they have a chronic cough or they have a cough, they've tried things, nothing's working, they want to try an antacid or a PPI or something for a month, that might be very reasonable.
Yeah.
Yeah, well, if they have, just, if they say, do you have a funny taste in your mouth, other things like that, yeah.